It's going.
Okay. So this is our new patient mobility initiative that we're starting. So for you, this is all new, and then for you guys, this will be replacing progressive upright mobility. So progressive upright mobility is going away, like next week. So the program that we're going to be using is called Johns Hopkins Mobility, and you'll start seeing this again on like next week. So it was developed by Johns Hopkins Hospital, and they did a bunch of like evidence-based research, and what they found was that when they implemented this program, that all of the negative things associated with bed rest really decreased. So they had a decreased risk of blood clots, a decreased risk of pneumonia, decreased risk of skin breakdown, decreased risk of contractures, and people didn't lose so much muscle mass when they're on this new program. So what it looks like is this, the Johns Hopkins Mobility Goal calculation. This will actually be one of the pop-ups that you'll see in Epic. And so the nurses will do an assessment on the patient at the beginning, at least once per shift. And then that assessment, they put theirs in, and then through the magic of computers, it will spit out a highest level of mobility goal. So it'll give you a number. You hover over that row, and then this is actually going to pop up. So the mobility goal is anywhere from 1 to 8. 1 being the patient is on bed rest, and then 8 being like the most mobile that the patient can be, 250 feet or more. It also spits out a recommended assistive devices. So they did all their research, and they found that like if they were, if all they could do was sit at the edge of the bed, they might need a sitting support device, which would be like a wedge kind of thing. So you don't have to use those particular devices. It's just a suggestion that they think goes well with that particular category. So the nurses do their assessment, and then the goal is there for everybody to see. So that goal is really like a minimum goal for the day. The next thing that you're going to see is the verify current activity order with the RN. So it was really the doctors and also physical therapy who wanted to get this program going. So the hospitalists are all about it, the intensivists are all about it. Most of the surgeons are, but the only kind of out there one would be like the orthopedic surgeons. Because a lot of times they have very specific movements that they do and do not want their patients to do. Like if they had a hip replacement or a knee replacement, then they have restrictive mobility activity orders, right? So when you click this drop down, you're going to get 2 options. Either it's okay to use the Johns Hopkins goal or follow the current activity order. So this will pretty much be either full bed rest or some ortho special order. And the people who do our Epic, they built this specifically to make the nurse and the nurse aide talk to each other and make sure that they're both tracking like what the order is. Because maybe the orthopedic surgeon will have like specific orders for a few days, but the patient continues to stay, and then they're going to switch over to Johns Hopkins. But you wouldn't have any way to know that unless the nurse told you that. So it just forces that communication. And then part of the nursing assessment, they will also determine the level of assistance. So like a 1-person assist, 2-person assist, that kind of thing. And then the suggested devices. So like your walker, your wheelchair, cane, whatever. Then the highest level of mobility performed will be what we actually chart when we see the patient physically move. So, for example, in the last one, the patient's mobility goal was a 4. So a level 4 is move to the chair or bedside commode. So say you go check on your patient, it's first part of your shift, and you say, okay, how about we get up to the chair? And they say, no, I'm really tired, I have pain, I don't want to get up to this bedside chair. But you say, what about sitting at the edge of the bed? Okay, fine, I'll sit at the edge of the bed. So then you could chart a 3, because they achieved that, they sat at the edge of the bed. Then say they take a nap, had some pain medication, they're feeling a lot better, then at lunchtime or dinner time, whatever, say how would you like to get up to the chair now? Okay, fine, we'll get up to the chair now. So then you chart their highest level was a 4. Then maybe as the day goes on, and then their family comes to visit, they're happy to see their family, they want to walk in the hallway. Okay, we're going to walk in the hallway because I feel great. So they just walk out their door and walk a few steps down. They walk 10 steps in. So then you would chart a 6. So again, that 4 is a minimum goal. Patients can be below, patients can be above. It just depends on what's going on with them. It's okay. The other thing that you can chart now, so again, the nurses will put this part in, 1 person, 2 person. The PT asked us to remind you about safe patient handling, of course, like always using your safe patient handling. And then to know that this program isn't a replacement for physical therapy, it's like in addition to physical therapy. So they're still gonna be doing their thing. In fact, they know that incorporating this program, they're gonna have more consults than they've ever had before. Because the way this is designed is to be like really aggressive with getting physical therapy on board when it's needed. So one other thing that you can chart now is if there were barriers to reaching the goal. So here we have our goal, it's like a 4. So maybe it's one of those ortho patients and there was no order to use Johns Hopkins. Well, that's why they didn't reach their goal, because it wasn't even ordered, so you click that. If there were no barriers and they met their goal, you click that. Clinical conditions, so maybe the nurse says, oh, their blood pressure is terrible, I don't want you to try to get them up, or we just started them on a new drip and they're not safe to get out of bed. So you could say clinical condition prohibits. Sometimes the family refuses, right? Sometimes the family's like, no, we're not gonna do this right now. Sometimes the patient refuses. Sometimes the patient has too much pain. Or maybe the doctor put in the order for total bed rest. So now you have a drop down where you can say why they didn't meet that particular goal. So what the providers are hoping is to be able to see over the course of time that the patient is improving. That's what we're hoping, right? That they're getting a little bit better and they're climbing up that chart every day. If consistently they're not able to meet their goal, then they want to know that, because if their pain's not being managed, then maybe they need to do something totally different for pain. Or if they're still not able to meet their goal, maybe there's some underlying diagnosis that they haven't even figured out yet. So they want that like visibility of what's going on with the patient so they can intervene sooner. So to help with that, on your desk, you'll see a laminated sheet that looks like this. So Johns Hopkins built this and we kind of adapted it for Talimoni. And so this tries to get everybody on the same page. Physical therapy, nursing, provider, and the Johns Hopkins really wants the patients and family members to also be involved in this. So this is gonna be in the patient room on the little silver bar, like where we used to keep the papers and the stickers, like when you first walk in. So you can use a dry erase on this. So we put the date and then the doctor's order, meaning if they want the patient ambulated or whatever, mobilized twice a day, 3 times a day, 4 times a day, however many times a day. And remember how I said we want to see that they're progressing? So we would indicate what yesterday's highest level was. So maybe like in our example, yesterday's highest level was a 4. So we would mark that. Then today, the nurse does their assessment and the goal is a 5. So say physical therapy comes to work with the patient and they walk 25 feet, so they can put a tally mark here. And then you get the patient up to the commode, then you can put a tally mark there. And then they stand to brush their teeth, you can put a tally mark there. They've been mobilized 3 times, and we know where they're at. And then we know that the highest that they were able to do was the 7. So basically every time somebody, whether it's PT or nursing staff, moves the patient, we would know where they're at. And it's just an eyeball. The whole idea also is to get the family involved. So really pulling the family members in, like, hey, so we know that they really want to go home. Well, one of the things that they need to do before they go home or before they can transfer out is we need to really have them walking or moving. Can you help us? Like, get them, be kind of a cheerleader, and like get them motivated to move. Because sometimes they'll listen to the family, they won't listen to us, right? So PT gave us this map so that we would have an idea of what the distances are. Because there's a lot of numbers on this thing. 25 feet, 250 feet, well, how do we know what's 250 feet? So this is like if you're looking down on the nursing unit, like the manager's offices are on the side, obviously the nursing station, and that's the public elevator and the staff elevator. So if they walk around the whole entire nursing unit, that's 400 feet. If they do the purple rectangle, so from the manager's office down to the nursing station and back, 250. And then the blue one, if they go by the staff elevator, down to that funny hall with all the weird angles, and then back. And then the orange circle is if they can't quite get that far. So maybe they have to split the distance. And you've probably seen them put these up on the unit. Like, why are they putting these flowers on the wall? This is why. So again, because Johns Hopkins wants everybody to be on the same page with what the distances are, and also to get patients, give them a goal. So these flowers were purposely placed 10 feet apart. So if somebody was, up ad lib, or like a one-person assist, you could say, hey, I want you to walk 3 flowers, or 2 flowers, or whatever. Then they know exactly like how far they're going, and then you can also gauge how far that they went, and that would be what you can chart, how many flowers they went, so 10 feet, 20 feet, 30 feet. So an example of a level 1 and 2, these are people who are either on bed rest or a complete dependent transfer. So these are people that require 3 or more staff members, people who require a lift, or like a surfboard to get from the gurney to the bed, right? So they're very, very limited with their mobility. So really all they can do is range of motion. Whether that's active or passive range of motion, they're kind of limited. So this is their max. They're not really able to do more than that. Then as we go up, hopefully most of your patients will be on the higher levels. So an example of a level 3 would be somebody who is able to sit at the edge of the bed. Now, one thing that's different with Johns Hopkins, or important with Johns Hopkins, is that we don't count assistive devices against them. So even if the patient had to use the side rail to get themselves up to the edge of the bed, we don't like subtract points or anything like that. As long as they made it to that position, they get credit for it. So it would be the same with 4. Moving to the chair or commode. If they had to use a walker, that's okay. They still earned it. They still get credit for a 4. And 5, so standing for a minute or more. Maybe they needed a walker or their cane to stand, but they were still able to do it. Then they get credit for it. So here is a video example. Very good actors.
Yeah.
Did you say so? So what level would you give them?
Sitting at the edge of the bed would be 3.
Right. So even though the patient had to use the side rail, even though they had to use the hand of the patient or the nurse, they still got up to the edge of the bed, so they still get the 3. And a lot of people do that, right? Like they can get over, but they can't necessarily get up because they don't have like the core strength to do that. So, but that's okay. Still get a 3. So these are things that Johns Hopkins just recommends kind of challenging the patient with, and I know you guys do this anyway, but if they're able to sit at the edge of the bed, then like, hey, while you're sitting at the edge of the bed, can you wash your face? You can brush your teeth from here or whatever. It's really just a matter of like minimizing the time they're in bed, maximizing the time that they're just not laying flat in bed. Another video example. We got the walker, we got the gait belt, the nurse is there, close by. Use the side rail to lower yourself down. But made it to the chair. What do you think?
4.
4, exactly. Because the devices don't count against. So if your patient's a level 4 or 5, then these are things that we would just encourage them to do. And that it's really changing the mindset of like even a tiny bit of movement is good movement. No matter your patient's mobility goal is a 6, but the patient's able to walk 25 feet. Do we restrict them to the level 6, or do we let them go?
Let them go.
Let them go, right. So if they feel strong enough and you feel like it's safe, we don't want to hold them back. That's a minimum goal for the day. They can always go above, they can always go over. It just depends on what's going on with the patient, how strong they feel. We don't want to hold them back. So if they walk 150 feet and then they have to sit down to take a rest because they're tired, but then they walk 100 more feet, what do we give them credit for?
Not sure.
They sat on their walker. They walked 150, they sat on their walker, then they felt better, they walked another 100. Give them credit for the full 250.
Yeah.
So you still consider that part of the same session. So they get credit for the 250. So, and this again, this is just even tiny things, like walking to and from the door, walking to and from the bathroom, standing to do different things. Every little bit helps because it keeps them out of bed. So as they get higher on the chart, right, level 6, 7, 8, this is really where, you know, if they're more stable, we can ask the family member to help take part, right? So if you can walk down the hall with your family member, that would be really great. You know, as long as it's safe and you feel like they're able to do that, and the orders say that they're able to do that, you know, I need you to walk. Do you want to walk before lunch or after lunch? Like, don't even give them too much of a, it's like kids, red pajamas or blue pajamas, before lunch or after lunch. So that way, like, I'm giving you a choice, but these are your choices. We're gonna walk, because we need to do this today, right? Does the patient have to be completely independent with ambulation to score one of those higher levels, 6, 7, or 8? What if they need assistance or supervision to ambulate safely? Can they still score the high score?
Yeah.
What if they have a bunch of medical devices? What if they have like a Foley and a chest tube, and then they have an IV pump, but they have to use a walker and you have to help them because they have so much stuff? Does that count against? No, it's not their fault. They have a lot of stuff, right? So just so you know, the elevator bay, like from the pink tiles to the pink tiles, that's 25 feet. And it's actually the same as the nursing station. It's also 25 feet. So say that the patient came from the other room on the opposite side, made it to the end, and then made it back.
That's 25 feet.
So you can choose either 25 feet or more or 250. It was at least 25,
Yeah.
but not quite 250. So you still give them credit for the 7.
So you said which is 25 feet from?
25 is the pink
The
to pink.
orange. Oh.
Because
Okay.
like see there's that square?
Yeah.
Yeah. So it's from there to there is 25 feet.
Oh.
So if they did
Insane.
there and back, we got at least 50. And then say it's another 5 feet to the door and maybe another 5 feet to the bed, then it's definitely not 250. Yeah. So we give them credit for the 7. Alright, so what if my patient has physical therapy? So this is kind of a workflow in progress. So you know on your communication board, if they have PT consulted, then it'll have the physical therapist name, right? What if you want to know more? You can add this column called rehab on your patient list. So if you see a name, that means that they're going to have physical therapy with that person. If you see 2 names, they're going to have physical therapy twice. So you can guarantee they're going to come, if there's 2 names, you're going to see 2 people at some point in time. And 1 name, 1 person. And then the other way to figure it out would be when you have your patient list up, you can hover your mouse over the provider's name, and then the treatment team pops up. So you'll be able to see the doctor, the nurse, the charge nurse, you'll see your name, and then same thing. If there's 2 physical therapists or PT and OT, then you know they're going to come twice a day. because they've assigned themselves to that patient, so they're gonna be there. So one request from PT is that if they're consulted, that they work with the patient before you do. So a lot of our patients, it depends on how they do with physical therapy before they can be transferred, especially to like a nursing home or a long-term care facility, right? They have to have like a minimum level of strength to be able to go to that other facility. So the concern would be if you walked with the patient first and then the patient gets tired, then when PT comes to evaluate them, they won't be fresh, right? So it won't be like a good score for them. And so it could be detrimental to the patient, and then they would have to like stay in the hospital for longer. So if you see PT as on your treatment team, then let them walk the patient first. So you can still sit them up on the edge of the bed, they can still dangle, they can do all of those like edge of the bed things, but as far as like aggressively like really pushing it to walk, let PT do that first. That's their request. And so because this is new, these are just kind of what all the team was like troubleshooting to figure out how to have that communication. So if you feel like that's not working and you need better communication, then let us know. We'll try us or your management or PT, because they want this to work. Like they're very excited about it and they want this to be successful, but it takes, all of us working together to how to make sense. So if it doesn't make sense for you, then it's not gonna work. So let us know if it's a problem. Alright, so questions? Concerns? I can tell you that nursing's concern when we were teaching them this was falls. And PT said the same. Everybody's worried about falls because we don't want anybody to fall. So it was kind of well, if we're getting people up a lot more, then aren't they at risk for falls? Well, it's like a double-edged sword. So we know that if they're in bed, they're at risk of all of those terrible complications. And we know that if they're up and walking more, maybe they are at risk for falls. So there's kind of two things that we have to pay attention to, and using your own clinical judgment is really important. So if you have been working with that patient and you get them up and you're like, there is no way that this person is going to be able to walk anywhere because they're just too weak, then use your own judgment because you know that that's going to be unsafe for that patient. So you can always rely on that, and then also remember that the longer somebody stays in bed, the weaker they get. So even doing little things will help prevent that sort of regression and that weakness from really setting in. So those are kind of